of HIV, an infectious disease, has earned him accolades and the utmost respect from colleagues and patients alike. As an esteemed speaker, Dr. Sanjay Pujari, sir, has shared his expertise and insights in various prestigious conferences, symposiums, and academic institutions. His dedication to education and knowledge dissemination has empowered countless professionals to stay abreast of the latest developments in their respective fields. Today, we are fortunate to have Dr. Sanjay Pujari, sir, here with us to shed light on contemporary HIV management, a primer for physicians. With his unparalleled expertise and ability to communicate complex medical concepts in a relatable manner, sir will undoubtedly provide us with invaluable insights, perspective, and practical guidance. Let me take this opportunity to introduce Dr. Sanjay Pujari, sir. Sir is the Director and Chief Consultant at Institute of Infectious Diseases, Pune. Sir is also consultant in HIV medicine and infectious disease at Pune Hospital Research Center. Sir is the principal investigator for therapeutics research education in AIDS treatment, Tritatia for the Pune site, and strategic timing of antiretroviral treatments, the START study at the Pune site. Sir has presented and published numerous papers nationally and internationally, majority of them which are PubMed indexed. Sir has been a faculty at numerous symposiums, including the European AIDS Clinical Society Advanced Course. Without further ado, please join me in extending a warm welcome to Dr. Sanjay Pujari, sir. We are honored to have you, sir, and we eagerly await your enlightening presentation. Over to you, sir.
Thank you. Can I share my screen, please?
Yes, sir. Please.
Yeah, good evening, everybody. At the outset, let me thank MCure for providing this opportunity to summarize HIV management as we look at it in 2023. So this is the outline of my presentation. I will basically focus on some of the important initial evaluation parameters as physicians that we need to do when a patient is diagnosed with HIV, and then we will shift to some of the important advances in opportunistic infections, some of the latest information associated with management of those. Then, of course, we will talk about contemporary antiretroviral therapy. And finally, we'll talk about some important advances in PrEP, that is pre-exposure prophylaxis, and post-exposure prophylaxis in the HIV context. So first and foremost is the diagnosis of HIV infection. And this is something which has been there for some years now. But unfortunately, we don't really still see a significant proportion of us really following this algorithm. When you suspect HIV infection, you need to really screen an individual with the 4th generation HIV ELISA, which is basically the HIV duo, which screens both for P24 antigen as well as HIV antibodies. And the window period for that is roughly 3 weeks. So even with an ELISA, we don't really need to worry about the window period. With the 4th generation ELISA, it's around 3 weeks, and it's highly unlikely that it's 100% accurate around 4 to 5 weeks of exposure. If it is positive, then we need to find out whether an individual is infected with either HIV1 or HIV2, so that we can do a rapid tests which are available in the market, which can differentiate between HIV1 and 2. If HIV1 is positive, it's HIV1 infection. If HIV2 is positive, it's an HIV2 infection. If both are positive, then it's a dual infection with HIV1 and 2. The problem comes if it is negative or indeterminate. Then you do a viral load, and if the viral load is positive, that means it's an acute HIV infection. And if the viral load is negative or the RNA is negative, then the patient has a false positive 4th generation ELISA with a negative differentiation assay. There has been a very interesting paper recently published in the Clinical Infectious Disease, which looks at acute COVID-19 patients who are PCR positive with COVID-19 within 3 to 4 weeks of the diagnosis of COVID-19 with an RT-PCR or a rapid antigen test have a higher rate of false positive fourth generation ELISA. So when you evaluate these patients, you need to really perhaps if there is a discordant result between fourth generation and the differentiation assay, then you need to really think about false positivity secondary to the COVID-19. So the take-home message really here is Western blot is an obsolete test. You don't need to do a Western blot for confirmation of HIV-1 infection. You just need a sequential fourth generation ELISA followed by a HIV-1-2 differentiation ELISA. So we still see in our practice patients being diagnosed or being asked to do a Western blot. This is not really recommended anymore. It is an obsolete test. In the initial evaluation, when a patient comes to you, they usually come with symptoms or they may be asymptomatic, but if they come with symptoms, you need to rule out opportunistic infections. You need to perform the CD4 counts. You need to screen for cryptococcal infection routinely by a serum cryptococcal antigen test when the CD4 is less than 100 and optional when the CD4 is between 100 to 200. So please screen with the cryptococcal antigen, because if that is positive, then you need to rule out CNS cryptococcosis by performing an LP and repeating a CRAG in the CSF. And if it is positive, then the patient is having an asymptomatic cryptococcal meningitis, and that needs to be treated as I'll mention about how to treat cryptococcal meningitis. And finally, for all of these patients, regardless of the CD4 count, you need to screen them for co-infection with hepatitis B, hepatitis C. We need to rule out other sexually transmitted infections like VDRL. You need to perform a routine blood count, a creatinine. And now this is very important. You need to perhaps have a baseline sugar as well as lipids, because increasingly it is being realized the issue of dyslipidemia and hyperglycemia happening with contemporary ART. So it's always good to have a baseline metabolic profile available for the patient prior to initiating ART. The second very important aspect, which is very, very critical, is doing a cervical pap smear screening or an HPV DNA evaluation from the cervix, cervical secretions for all women who are HIV positive. This is important because the incidence of invasive cervical cancer as well as cervical intraepithelial neoplasia is higher in HIV positive women as compared to HIV negative. So it's very important to screen for them, screen for this condition at baseline, and then repeat the screening every 3 years. It's very, very important. And we have been doing it in our practice routinely by referring it to another organization which performs this for our patients. And we have been able to pick up a significant proportion of women with cervical intraepithelial neoplasia so that you can treat them and prevent their progression to invasive cervical cancer. And finally, for all of your patients, you need to do what is called as a W4SS screening. We'll talk about it in the opportunistic infection section. So what is this W4SS simple tool for TB screening? For every HIV patient who comes to you, you need to ask them 4 symptoms. The 4 symptoms includes weight loss, fever, night sweats, and cough. So these are the 4 symptoms. If you are able to see any of these symptoms, then you need to evaluate the patient further for ruling out tuberculosis or any other opportunistic infection. But the patient has none of these, and if the patient is not on antiretroviral treatment, then the negative predictive value for ruling out tuberculosis is almost 100%. So if the patient doesn't have any of these symptoms, regardless of the CD4 count, the CFSW rule, that is the cough, fever, night sweats, and weight loss, in that situation, the patient is unlikely to have tuberculosis. So it's a very important screening symptomatic tool for tuberculosis screening. You must have seen this in the government programs where they write in the ART notes that the CFSW rule is negative. So it is something which is very, very important that we also do in our private setups. So take this history at each follow-up visit. This is very, very important because TB can happen at any point during the course of HIV infection, regardless of whether a patient is on ART or not. Of course, with ART, you have a reduced risk of developing active tuberculosis as compared to not being on ART. The second most important thing is when you screen for tuberculosis, it's very important to move away from AFB, etc. So now we have molecular tests available, and these molecular tests are now being recommended for screening of tuberculosis. So you may not need to do an AFB staining. You can directly ask for an expert MTB Ultra, which is available, or a TrueNat, CBNat, which is available very, very routinely across India. And now we have this Expert Ultra. Previously, we used to have the Expert MTB/RIF. The Ultra is supposed to be more sensitive, but a little less specific. And this is something which is very, very useful even in smear negative sputum tuberculosis. So even if the AB is negative, then the Ultra can help you. So that is why screening is being recommended with the molecular tests. The only role where you may see that AB can really help, the staining, is that when you have a discordant result, if the AB is positive but the Expert Ultra is negative, then it is likely that this patient may have a typical mycobacterial infection. Either it can be Mycobacterium avium intracellulare, or it can be Mycobacterium kansasi, or any of the other rapid growing mycobacteria. So that is the only situation where an AB will help you if you're suspecting a typical mycobacterial infection. But otherwise, you should routinely screen with the molecular test. And this is a WHO recommendation that amongst all adults and adolescents living with HIV, molecular rapid diagnostic tests should be used or may be used to screen for tuberculosis. So this is something which we should follow in our practices as well. What about extrapulmonary tuberculosis? There is now emerging evidence to suggest that Expert Ultra also performs very well in diagnosis of extrapulmonary tuberculosis. So this is some data available for tubercular meningitis, where it is the screening method of choice in the CSF to do an Expert MTB Ultra for diagnosis of tubercular meningitis, except that you need to process the CSF by centrifuging it and actually screening the sediment for Expert Ultra, which increases the sensitivity of diagnosing tubercular meningitis. There is data available for lymphadenitis as well. We routinely do it in the lymphadenitis scenario also to not only confirm the tuberculous infection, but also to find out whether there is baseline rifampicin resistance. It is very, very important to rule out rifampicin resistance at baseline, because then automatically this patient needs an MDR-TB regimen for management of tuberculosis. So the Expert Ultra has two advantages: it's help for screening of tuberculosis and diagnosis of TB, but at the same time it helps us in knowing whether the patient has rifampicin resistance at baseline. This is important because we have a significant proportion of patients who come to us with no past history of TB, who still are found to have MDR-TB at baseline in the context of HIV. So please rule this out. So that the most important thing, the message that I want to give you here is that tuberculosis diagnosis, whether in the HIV context or HIV negative context, is no longer empirical and no longer radiological. We should have a microbiologic proof. Particularly, molecular methods increase the sensitivity for diagnosing this, as well as they're important to tell us something about rifampicin resistance. Sometimes you can go in for other molecular methods which are available for diagnosis of INH resistance as well. And there are now molecular methods available for diagnosis of fluoroquinolone, ethambutol, and aminoglycoside resistance as well. So this basically can give you in a rapid turnaround time the diagnosis of MDR, XDR, TB, etc. at baseline with a rapid, without waiting for the traditional culture sensitivity report to initiate treatment and manage these patients with drug-resistant TB. There's another important advance in managing tuberculosis, which is drug susceptible in the pulmonary compartment. And this is one of the studies which was not only done only in HIV, but it was also done in the entire population, out of which a subset were HIV positive. And this data is from a paper which was recently published in the HIV positive population. And this is what is called as a short course rifampicin moxi regimen for drug susceptible pulmonary tuberculosis. So as you may see here, this is a standard 2-HRZE4-HR, which is a control arm, which is compared with the rifampicin being replaced by rifampicin for 4 months, and then the ethambutol being replaced by moxifloxacin for a period of 4 months. As compared to 6 months, we have narrowed down to 4 months. So what this study really shows is not much effect as far as only replacing rifampicin for rifampicin is concerned for shortening the duration of TB treatment. But rifampicin along with moxifloxacin as a good treatment effect was non-inferior to the control arm. So, and was safer as well in the HIV positive population, as well as the data published in the New England is for the entire population. So this is something which is a game changer. Rifampicin is available in India, but unfortunately it is not very widely available in the market still, and there is still some problems going on in terms of trying to find out what is the market available in this country. So rifampicin, if it comes in the private market, is really going to help in shortening the duration of TB treatment in the HIV positive as well as negative. For the pulmonary TB drug susceptible, of course, we can't still use it in the extrapulmonary TB format. But also it is useful for preventing TB, and we'll talk about it, the role of rifampicin in primary prophylaxis of tuberculosis treatment. So as is a summary here, the rifampicin moxifloxacin is an emerging option for the treatment of drug susceptible TB in pulmonary TB in people living with HIV. And this is a study, these are 2 studies which basically shows its role in preventing, in the use of using it as tuberculosis preventive treatment in the HIV context. We all know we have been using 9 months of INH as a standard of care for preventing TB when you initiate ART, regardless of the CD4 count for preventing TB. While it is beneficial, we know that 9 months of IPT is something which has very difficult completion rates. Patients may not be adherent to that kind of a treatment. It increases the pill burden along with the ART. So people have compared 1 month of daily INH with rifampicin, and people have compared 3 months of weekly INH with rifampicin. So that is almost just 12 doses of the drug, and both have been found to be non-inferior to the standard 9 months of INH for preventing tuberculosis. Not only was that, but it had higher completion rates of completing your tubercular preventive treatment, as well as it was safe. And at this point of time, drug-drug interactions with rifampicin are not as strong with ARVs as rifampicin. So at this point of time, you can perhaps use it concomitantly with the ARV drugs that we are going to use. So these are the options recommended for the treatment of latent TB, regardless of CD4 count in the HIV context. If we have no access to a rifampicin, then we can't obviously use 1 HP or 3 HP, but we can look at using 6 or 9 months of daily isoniazid or 3-month regimen of daily isoniazid plus rifampicin. But of course, that is something which is limited by drug-drug interactions from the rifampicin. There's another very important advance that has come in last year is in the management of cryptococcal meningitis in the HIV positive scenario. We know we have been managing cryptococcal meningitis by a long duration of conventional or liposomal amphotericin B treatment, which goes on for 2 weeks with flucytosine and then go on to a consolidation phase of using fluconazole. But this study called the Ambition CM trial looked at a single high-dose liposomal amphotericin B. So 10 milligram per kilogram of a high-dose liposomal amphotericin B along with flucytosine and fluconazole for the remaining 2 weeks was non-inferior to the conventional 2 weeks treatment. So this is all-cause mortality at week 10. It's a very hard endpoint. There was no difference, as you see, between a single high-dose liposomal amphotericin B versus the control. In some specific analysis, they actually showed superiority of single-dose liposomal amphotericin B. And we all know that liposomal amphotericin B is safer than conventional amphotericin B in terms of development of rigors, development of renal toxicity, development of hypokalemia. So all of these things were lesser and more safer with the liposomal amphotericin. So this is something which is important because what it really shows is induction therapy for cryptococcal meningitis now recommended by most organizations, including the World Health Organization, is a single high dose 10 milligram per kilogram of liposomal amphotericin B, plus completing that with 14 days of flucytosine and 14 days of fluconazole as an induction therapy. So what it means is avoiding hospitalization costs, being more safer, and the patient can go back home in 1 or 2 days if the CSF pressure is not very high and you're not going to do a CSF letting every alternate day for the patient. So this is something which we have already started following in our clinical practice of whatever cryptococcal meningitis we are seeing, because now we are seeing very less opportunistic infections in our own practices. The other thing is we find that many patients who are on ART, who are doing well, who their CD4 counts are good, are still continuing to use OI prophylaxis like say TMP SMX. And this is a very old study really, which shows that the incidence of opportunistic infection is no difference between those who discontinue prophylaxis, both primary or secondary for OIs, as compared to continuation. So the take-home message is for primary or secondary OI prophylaxis, you can discontinue those if a patient is on stable antiretroviral therapy with the CD4 more than 100 and a viral load of less than 50 copies for a period of 6 months. So we don't need to burden the patient with higher pill burden for this context. Now let us come to the crux discussion, and that is what are the real issues in antiretroviral therapy in the contemporary era. The first and most important thing that has come up is what is called as rapid ART initiation. Now we used to, when we used to practice some years ago, used to counsel the patient about ART, assess their financial stability, and then what we used to call as readiness of the patient, ask them to go back home and come back for reinitiation of ART after a period of 1 week or 2 weeks. But this rapid ART initiation is what is same day antiretroviral treatment. So as soon as you diagnose the patient, then you initiate antiretroviral therapy after talking to the patient, and as early as possible for the patient within a period of a week for starting ART. So this is moving away from, very intensive counseling to look for readiness, etc., to starting ART. But if a patient is not affordable, it is more prudent to send a patient to the free program, which is transitioning to a TLD regimen in a very large way, where they can access the best regimens which are currently recommended for their treatment of HIV infection. Only if a patient can afford, we can keep them in our practices and initiate them on some of these newer regimens. So it should be offered to all HIV infected individuals, except remember in patients with tubercular meningitis and cryptococcal meningitis, you need to delay the initiation of ART until up from 2 weeks to up to 6 weeks, so that you can prevent the development of iris in the CNS compartment, which can have some mortality effect because of rapid initiation of ART. So apart from these two conditions, most of your patients, you can afford to initiate ART very rapidly. Now, what are the preferred regimens for antiretroviral therapy? Naive patient who has not been exposed to ARVs in the past, well, there is a lot of data available there. These are some long-term data available looking at the NAMSAL trial in Africa, which compared TLD versus TLE, and as you see here, there is no difference in the rates of virologic suppression, even as when you stratify it according to whether the baseline viral load is less than 100,000 or more than 100,000 copies. And this is a study which is looking at bictegravir And this is data up to 5 years. As you can see, the durability of viral suppression is excellent. In the missing is equal to excluded versus missing is equal to failure. So this is a single arm kind of analysis which shows that these drugs are very, very potent, and these drugs hardly any resistance seen when you fail on this regimens. The viral load can be resuppressed if you initiate the same regimen again for the patient without worrying about the low genetic barrier to resistance associated with the previous drugs that we are using, like efavirenz or rifampicin. So this is the current recommendation is using a core ARV, which consists of an integrase inhibitor, either dolutegravir or bictegravir. If a patient cannot have access to these two integrase inhibitors, or if the patient is highly intolerant to these two integrase inhibitors, you can consider using an efavirenz 400 milligram for this patient. This is combined with the backbone of two nucleoside reverse transcriptase inhibitors. Either it can be TDF3TC or a TAF-FTC or an abacavir 3TC. So this is a very simple regimen which is available now as fixed dose single tablet regimen for all the combinations that we are talking about, except of course with efavirenz 400, you have it only with TDF. But for the other drugs, for bictegravir, you have it only with TAF-FTC, but with DTG, you can have it with all the three as a single tablet regimen. So that really helps you in terms of adherence. So this is the crux of what is the ARV regimen that you're going to use in your HIV in positive individuals who are initiating ART for the first time. But there is an increased interest in looking at two drugs only now, since DTG is the very powerful drug which has a very high genetic barrier to resistance, and in naive populations you hardly see resistance to dolutegravir happening. So both in naive patients as well as in patients who are stably virologically suppressed with no historical resistance to lamivudine and who are HBV negative, you can switch these patients to a two-drug regimen of DTG3TC. We have been using in a significant proportion of patients a two-drug ARV regimen, either because there is a concern of TDF-associated nephrotoxicity or TAF-associated weight gain, as well as metabolic complications like dyslipidemia and hyperglycemia. So these are the pooled analysis of the Gemini 1 and 2 trial. And this is a simplification study, pooled analysis at week 48 of the Tango and the Salsa trial, where the two-drug regimen has been shown to be non-inferior to a standard three-drug regimen. So this is also some paradigm shift in contemporary ART. So two-drug ARVs can be used in most of your population with few exceptions. So in the naive population, if the viral load is more than 100,000, or if a patient is hepatitis B positive, then you can't use a DTG3TC. In simplification, you have to make sure that the patient has no historical DTG or 3TC resistance, and the patient has to be suppressed on a previous regimen. Now, this previous regimen can be anything. It can be an efavirenz regimen, it can be a PI regimen, it can be a nevirapine regimen. So from or the backbones can be abacavir or TAF or TDF. In all these contexts, a two-drug regimen, if there has been no historical 3TC resistance, that means these two drugs are really new in terms of resistance for the patient, you can shift these patients to DTG3TC. So in most patients, you may be able to reduce the number of exposure to the antiretroviral drugs that are being used for these patients. For tuberculosis, unfortunately, we have only two options available. The efavirenz 600 milligram can be given with rifampicin. And when you use dolutegravir, you need to use this as a BID, as has been shown in this inspiring study. So the take-home message is for HIV tuberculosis, when we are using rifampicin for TB treatment, you need to either use a efavirenz 600 milligram or increase the dose of dolutegravir to BID. And most importantly, do not use TAF. And because we don't have much clinical evidence for that, there is some PK data available that it can be given with rifampicin. But TAF basically levels go down when you give it with rifampicin. So do not use TAF at this point of time when you are managing HIV TB and the TB with rifampicin. Once you start somebody on ART, will be monitoring them. Previously we used to monitor them with CD4 counts and viral load. But now we know that once somebody is stably suppressed on viral load has achieved an undetectable level, the problem of developing a future virologic failure if the patient continues to be adherent to the medication is absolutely zero. So only if the viral load is in the low level viremia phase, or if it is failing more than 200 copies, you will see some failures happening in that context. In terms of CD4 count, as you see here, there is always a rapid increase in CD4 count after starting ART, but then subsequently it plateaus off. So that essentially means there is no point in monitoring the CD4 count once a patient has a stable CD4 count and the patient is expected to be suppressed. So the recommendation is that you ideally need to monitor viral load every 6 months to make sure that the patient has less than 50 copies and is not going to more than 200 copies, because more than 200 copies would mean virologic failure. For CD4 counts, you initially do it every 6 months, but after CD4 is achieved to more than 500, and if the patient has undetectable viral load, and if the patient is adherent to ART, you don't need to do CD4 counts. We have stopped doing CD4 counts in this group of patients, and we monitor them only with the viral load. But for all of these things to happen, you need to really make sure that these patients are adhering to their antiretroviral therapy, and assessment of that at each visit is important. The other issue, and this is a very dramatic advance that has happened, is looking at when you fail a first line NNRTI based regimen, what do you shift to? Normally, we used to shift to a boosted protease inhibitor like atazanavir, ritonavir, or lopinavir initially, or darunavir, ritonavir, and change the backbone nucleoside. If somebody was on tenofovir, shift them to AZT, etc. But this study, the data now available for 96 weeks, called the Nadia trial, in which patients who failed first-line efavirenz-based regimen were randomized in a 2x2 factorial design to either switching to darunavir, ritonavir, or dolutegravir as the core drug, and then either shifting from TDF to AZT or continuing the TDF in the second-line regimen. In both the arms, whether it is dolutegravir or darunavir, ritonavir. And as you see here, there is no difference between individuals who continue TDF or switch to zidovudin in their second line regimen. So what it essentially means is that your core drug is so powerful, whether it is darunavir, ritonavir, or dolutegravir, in spite of having resistance to your tenofovir, partially resistant NRTIs, if you recycle them in your second line, it works fine for the patient, at least for 96 weeks. There is some concern about emerging DTG resistance in this context, but until that point of time that we have further analysis from this study, I think it is quite safe to do something like this. So if somebody is failing an efavirenz-based regimen, you can either use a dolutegravir-based regimen or a darunavir-ritonavir-based regimen, and there is no need to change the backbones. If the TDF, the patient was on TLE, you can shift them to TLD or a TL darunavir, ritonavir, depending on what is the choice. If the patient is failing a dolutegravir-based regimen, then you switch to a darunavir-based regimen. You can continue the same backbones that the patient was taking in the first line. And most important is, since nucleoside resistance, cross resistance is no longer an issue because your core drugs are so strong, you don't need to do resistance testing. And that is the reason why we have stopped doing resistance testing for most of our patients. When they come to us with failure of a TLE-based first-line regimen, we just shift them to either TLD or TL darunavir, ritonavir, and then monitor their viral loads to see if they are getting suppressed or not. So this is a very important advance that basically challenges our understanding of cross resistance amongst the NRTIs, and we really don't need to worry about sequencing the NRTIs when we have strong core ARV drugs like darunavir, ritonavir, and dolutegravir. What about somebody who is on a boosted protease inhibitor for second line? So this patient is with you, is on say TDF, 3TC, atazanavir, ritonavir for 8 to 10 years, and the patient is doing fine. The viral load is undetectable. The CD4 count is good. Can you shift that atazanavir, ritonavir, replace it, and substitute it with dolutegravir? So this is a study from Africa, which is called the 2SD study, where patients were randomized to continue the boosted protease inhibitor or switch to dolutegravir. And as you see here, in terms of virologic suppression, there was no difference in the rates of virologic suppression in these two arms. So the message here is, if a patient is on a PI ritonavir in second line and the viral load is less than 50 copies or 20 copies, you can safely substitute the boosted protease inhibitor to dolutegravir. And the boosted protease inhibitor that we are talking about, which was widely used in second line in India, was atazanavir ritonavir. Now we know atazanavir ritonavir has some issues related to nephrolithiasis. Itself can be nephrotoxic. It can cause some gallstones. So it's always prudent to shift this patient to DTG, particularly because this patient is going to be also shifted to a single tablet regimen, because we don't have a fixed dose combination for atazanavir ritonavir with the backbone of TDF. And you can continue the same backbone. So again, this is an important change. So as you see here, we are moving towards integrase inhibitors, whether it's first line, second line, as a treatment option available for our patients. Now we talked about the efficacy of ARV, but there is some toxicities associated with the contemporary ART, and the most important of that is weight gain. And this has been noted particularly in ARV naive population whom you initiate antiretroviral treatment. Weight gain is maximum with integrase inhibitor as compared to boosted protease inhibitor and or NNRTI. But if you look at the absolute weight gain difference that we are seeing is about 3 kgs of weight gain from baseline at week 96. Amongst the integrase inhibitors, bictegravir and dolutegravir has similar rates, and we don't have as much high weight gain in the elvetagravir group, though this drug is not available in India. Amongst the backbones, you will see TAF having a highest weight gain, followed by avacavir, followed by TDF. And we know zidovudin was actually associated with weight loss and lipoatrophy. So you don't see much weight gain in that context. So when you transition to integrase inhibitors and when you are combining TAF along with integrase inhibitor, you are going to see a significant proportion of patients with weight gain. Now, even in our practices, we are seeing weight gain in our population, but you should see it's quite heterogeneous in terms of that only a small proportion of patients will gain what is clinically significant weight gain of more than 5% or more than 10% of baseline. In our study, which is under review in a journal, about 30% of patients would have more than 5% or 10% weight gain in the switching scenario, not in the naive scenario, but in the switching scenario. Maybe in the naive scenario, you'll have a little higher percentage of patients who gain weight. So now in your practice, you need to really look for weight gain, calculate the BMIs, see if the patient is shifting into the BMI categories from normal to overweight or overweight to obese, and whether this weight gain is associated with metabolic problems. Really, that is something with which data is still unclear now. There is some signal to suggest that integrase inhibitors may be associated with higher risk of hyperglycemia, but dyslipidemia is quite neutral with integrase inhibitors. But we need to screen for this annually, at least in our patient population. And also, if these are high, do a CV risk assessment by CV risk calculators and design interventions like initiating statins, etc., for these patients in this context. This is a hot press data which was recently released as a press release. And this is the REPRIVE trial. The REPRIVE trial basically was a trial which looked at initiating pitavastatin in individuals on ART, comparing it with placebo and following them up to look for any prevention of CVD events, routinely initiating pitavastatin. So this trial was stopped in between, and this press release was mentioning that the trial was stopped in between because there was a reduction in CVD risk events by about 30% when you use pitavastatin as a primary prevention strategy along with ART in the HIV positive context. Now, we don't know, we have not seen the publication. It must be somewhere in press or under review. But what it gives us a potential look at using statins upfront along with ART to reduce these metabolic complications that we are talking about, particularly in terms of a composite outcome, preventing a composite outcome of CVD disease. The other issue which we are familiar with is nephrotoxicity with the TDF, which is much higher as compared to TAF. So this is something which we need to take care of. If the patient's eGFR is less than 90 ml, we would prefer to use TAF as compared to TDF if we are using a 3-drug combination, or if a patient is eligible, just don't use both of them and use a 2-drug combination. In terms of bone toxicity also, TDF is associated with more bone toxicity as compared to TAF. So when you have these patients on either TDF TAF, you need to monitor for creat urine, especially with TDF with comorbidities underlying like diabetes, hypertension, or when TDF is used with the boosted protease inhibitors. BMD studies can be done. We do it not routine screening, but only if a patient comes to us with a history of fragility fracture. Then we basically intervene based on calculating the FRAC score and advising bisphosphonates or other drugs which are used for preventing fractures in individuals with osteoporosis. Finally, this is something which we should all remember to do. Is a patient who is HIV positive and tuberculosis with a CD4 of less than 100 comes to you, you treat them for their TB. Now you initiate the ART after 2 weeks. At that point of time, you need to simultaneously initiate the patient on steroids. And this has been a randomized trial published long time back, which actually shows you that the TB-associated iris at 12 weeks is significantly lower if you initiate prednisolone along with ART in individuals with CD4 less than 100 and an HIV TB with controlled TB on ATT as compared to a placebo. So this is practice informing. We need to initiate prednisolone, as I told you, along with ART if the TB is responding to treatment and the CD4 is less than 100. So never forget to do that, because it prevents a lot of TB iris, particularly those glands which come up, which has to be drained repeatedly, and it is quite distressing for the patient. Some concern about neural tube defects with dolutegravir. This has been put to rest now with longer term data available from the SEPAMO study. It is now preferred ARV core drug irrespective of trimester, the DTG, or if a patient, even if the patient is trying to conceive, you need to give, you need to be feel safer to use DTG in this context. It doesn't lead to higher incidence of neural tube defects. What about mother to child transmission of HIV? This is data from a clinical trial, I think from the IMPACT study, where it has been found that TAF FTC DTG is reasonably a good option. So is TDF FTC, TDF FTC DTG. As compared to say efavirenz. So current recommendation is for if a patient who is ARV naive and a pregnant woman living with HIV, you can use a DTG based regimen in this woman because still we don't have data, good data for bictegravir. In fact, bictegravir has lower levels in pregnancy. So you can't use bictegravir in pregnancy, but you can use dolutegravir safely with either TAF FTC or TDF XTC. What about hepatitis HIV co-infection, hepatitis B HIV co-infection? This is from the Alliance study, which was carried out in Thailand, presented at Montreal earlier in the mid last year. It's a randomized trial comparing TAF FTC bictegravir with TDF dolutegravir, and surprisingly they found little better results, particularly in the E antigen positive seroconversion rates with TAF FTC bictegravir as compared to TDF DTG. So maybe TAF is a little better in this context, but I don't think it should be something which we should change our practices. Make sure that for HIV, HBV co-infection, we incorporate either TDF or TAF in the ARV regimen. And obviously, this is an indication where you will not use your 2-drug ARV regimen like DTG3TC. And finally, I think the most important advance in terms of improving the quality of life of our HIV positive patients using ART for prevention. And this was the HPTN 052 study, which showed that early initiation of ART reduces the risk of acquisition of HIV among serodiscordant couples as compared to delaying antiretroviral therapy. And this is the partners study, which basically looked at, it's an observational study, which looks at the risk of transmission of HIV, whether it is any form of anal sex, vaginal sex, men who have sex with men, heterosexual relationships, and found out that if you are undetectable, the risk of transmission of HIV, as you see in the point estimate, is 0. So what it essentially means is U is equal to U, that is undetectable in the blood, means untransmissible. This is something which we have been proactively telling our HIV positive discordant couples in our practice to maybe consider sex without condoms. Previously, when we talked about HIV prevention, we used to always make sure that, you use condoms. But now we have evidence to suggest that condomless sex is not risky if the source patient is adherent to ART and is undetectable. This is a very, very important message that needs to go down into our HIV positive surrogate discordant population which comes. So be proactive to communicate this important scientific advance to our patients. Finally, let me end by pre-exposure prophylaxis and PEP. We know that we can now use in high-risk individuals pre-exposure prophylaxis, usually daily, either with TDF-FTC or TAF-FTC. Both reduces the risk of acquisition of HIV, like an oral contraceptive pill, which prevents pregnancies. So you can recommend it in your practice for people who practice high-risk behaviors, or in HIV discordant couples in which one partner has still not achieved undetectable viral load. You can use TDF-FTC, or in the MSM population, use TAF-FTC, but also monitor renal. But most important is you should know it doesn't prevent other STIs like herpes or chlamydia or syphilis. So you still need to warn them that, from the HIV perspective, you're safe, you're taking PrEP, but you can still acquire some other STIs. Important advance not available in India is long-acting injectable antiretrovirals. Now, we know that ART has to be taken daily, but now we have cabotegravir with rilpivirine combination, which can be used every 4 weeks as an IM injection. And this is equivalent to taking daily ART. So naturally, people have looked at whether you can use long-acting injectables as a PrEP, and this is a long-acting injectable cabotegravir as compared to daily PrEP. As you see, a very high rate of efficacy in preventing HIV, because obviously this is injectable and these people have to take. They may not take it very, very regularly, so they have a higher incidence of acquiring HIV. So injectable ARV still not available in India, but this is an additional prevention choice available in the Western world. Finally, let me end by showing you post-exposure prophylaxis indication, because I still get many calls from all over the places about a healthcare worker getting a needle stick injury and wanting to know if they want to take PEP. Now, just focus on this. If the HIV positive source has an undetectable viral load, and if you have a high risk non-occupational exposure in the healthcare setting, ART is not recommended. So if the patient is undetectable, whatever forms of exposure that we already talked about, undetectable is equal to untransmissible. It is true for sexual. It's also true for non-sexual occupational exposures. So don't go for PEP if the source patient is undetectable. If the source patient has some detectable viral load, it's only sharps injuries that you may recommend post-exposure prophylaxis. And for post-exposure prophylaxis, within 72 hours, you need to initiate. You can use again an integrase inhibitor. So you see integrase inhibitors are everywhere. You need to take it for 28 days, and you need to rule out baseline HIV and HPV. So let me finish and take questions, because I think I've been talking for a little long, but I hope I simplified the topic and gave you an overview of what is the current understanding as far as management of HIV is concerned. So as we know, ART is just like any other chronic manageable illness like diabetes and hypertension. But I think there are new issues coming up, particularly metabolic issues, weight gain, This may be because of contemporary ART, or this may be because our patients are aging and this needs to be effectively screened for and managed. Very, very important. And I think this is, as all physicians, we need to communicate to our HIV positive patients that if you're undetectable, you can't transmit HIV. So there is no real need for you for using condoms while having sex. And PrEP is unfortunately, which is still very, very, it has been as a science available for the last decade or so, but its scale up has not happened. In our practices, patients coming to us, we have a lot of a young MSM population who come to us proactively seeking PrEP. So this is something which we need to communicate to. If a patient comes to you with a sexually transmitted infection, tell them about the option of PrEP which is available, which can prevent them from getting HIV. So I think that's all, and I will be happy to take questions. Thank you.
Thank you so much, sir, for such an insightful session. So we have one question from Mr. Balaji regarding pre-exposure prophylaxis. So should we on demand PrEP or daily PrEP?
Well, both have been shown to be effective, but there is certain data available which suggest that daily PrEP is better in as compared to on-demand PrEP. Because non-adherence on on-demand PrEP can have inadequate levels of the ARV drugs, while daily PrEP will have some drug levels available at the compartment site. But most guidelines do recommend daily PrEP, and on-demand PrEP, unless and until you have patients who are not willing for daily PrEP.
Thank you, sir. So now we can take up questions from our three locations one by one. So Ahmednagar group, we would like to start with you.
Yes. Yes.
Yeah. Please go ahead.
What we are seeing is a lot of lipodystrophy with dolutegravir. Very rapid, mostly head and neck. What is your experience?
Yeah, I think that is Dr. Warren. Hi, Dr. Warren.
Hi.
Hi. So yeah, so weight gain is something which we are seeing. It, as I said, it's not homogeneous. You will have a small proportion of patients, particularly women, particularly who are on TAF, also along with dolutegravir, which basically leads to weight gain. This weight gain is uniform weight gain. We don't see significantly any, who have a differential weight gain happening in the visceral compartment as compared to subcutaneous compartment. And studies have shown that both in the subcutaneous as well as the visceral compartment, the weight gain happens, the fat deposition happens in these patients. Interestingly, there is another idea to this, and the WHO believes this as well, that TDF and efavirenz have weight suppressing effect. So when you basically shift away from either of these two drugs to an integrase inhibitor or from a TDF to TAF, you see a rapid weight gain happening. But if you shift from, say, TLE to TLD, you will have effect of weight gain, which is not very high because you're just shifting from E to D, you're maintaining the TDF. But if you shift from TLE to TAF, TC, DTG, you will have a significant weight gain which happens. So I think we have two papers which are under review looking at this weight gain problem in the Indian population. As I told you that in the DTG-3TC group also we saw weight gain if somebody is shifting from TLE, because the suppressing effect of both TDF and efavirenz is gone and the patient is going to a DTG-3TC regimen. So just remember that, TDF and efavirenz may have a weight suppressing effect. If you remove them, then perhaps you may, there is a, now how do you manage that? Because we don't have answers for that. Whether you go back to your same regimen, there is no data available for that, but there is some very early data from the advanced study, which basically shifted patients in the African scenario in the TAF FTC DTG group to TDF 3TC DTG, and they found some weight loss happening. So from TAF to TDF back, you may see some weight loss happening. At this point, this is still very, very preliminary data. We're not suggesting you should shift them back, but this is something which may be kept at the back of your mind.
Thanks.
Yes, Bagalkot group has raised their hand. Yes.
Good evening, sir. Am I audible?
Yeah,
Yes.
Sir, I am Dr. Sandeep, nephrologist practicing in Bagalkot.
Yeah.
Thank you very much for a lucid talk, and it was very informative. My doubts are twofold. One, we have a lot of patients from government setup who get TLE regimen and who come to my clinical practice with renal dysfunction. So what would be the best drugs which I can shift? And number two, in already existing CKD patients and existing patients of and patients with acute kidney injury, what would be the best regimen for me to start those patients on?
Yeah, so the most important drug, offending drug for nephrotoxicity is TDF, followed to some extent by TAF. So TDF is the culprit drug, but TDF nephrotoxicity now studies have very clearly shown do not happen very commonly only when you combine them with, say, efavirenz. It happens when you combine them with a boosted protease inhibitor. So in that context, you will see a higher incidence of nephrotoxicity. Somebody who has an underlying additional cause for renal injury, like somebody who is diabetic, hypertensive, somebody who's on different nephrotoxic medications, you may have an additive effect of TDF causing that nephrotoxicity. So what you would use ARVs in this context is you can shift them to abacavir, because that is renal neutral, and you don't need to adjust the dose of abacavir in this context also. You don't need to adjust the lamivudine dose. Remember, we used to say that lamivudine dose needs to be adjusted, but there are now studies which suggest that lamivudine, even if it accumulates, doesn't cause toxicities. So you can use lamivudine. So you can shift them to abacavir lamivudine with an integrase inhibitor. But the problem with abacavir is there may be a little higher risk, CV risk associated with it, and particularly somebody who's diabetic, hypertensive, you're worried about the CV risk. In addition, if the patient is eligible, shift them to a 2-drug regimen, a dolutegravir with lamivudine. So in most of our patients with established CKD or with patients who develop CKD on TDF are preferred to be on a 2-drug regimen with DTG 3TC if there is no 3TC resistance identified in this.
Okay. Thank you so much, sir. Thank you very much.
Now, I would request Nanded group if they have any questions, as they have raised their hands previously. Nanded group, any questions?
Yes, we have typed.
Hello. Yeah.
Please.
Okay. So, any more questions from the?
Hello.
Yes.
Hello.
Yes.
Yeah, so I typed that question and unfortunately it got disconnected. So what is your opinion on the tuberculosis preventive treatment? Because it is a divided opinion that giving only isoniazid at many levels, we are promoting MDR-TB. So what is your opinion on that?
Yeah, so there is a reasonable scientific evidence available that if you use INH for a period of 6 to 9 months, along with antiretroviral therapy, it reduces the incidence of tuberculosis as compared to either used alone. So
Okay.
ART plus INH is good, is the best intervention available for preventing TB. One. Secondly, they have also showed long back in studies that if you develop breakthrough TB on INH, and if you sequence the tuberculosis for INH resistance, there is no INH resistance. So there is the concern about drug-resistant TB emerging on INH. It will be more likely INH-resistant TB. It will not happen with the use of INH.
Thank you. Thank you.
Thank you, everyone, for joining us today in this insightful and engaging webinar. I would like to thank our panelists, Dr. Marcia Varan and Dr. Satish Patke from Ahmednagar, Dr. P.M. Prabhu's Swamimat, Dr. Shaifullah Khan Inamdar, Dr. S.M. Gurnavar, Dr. Sangamesh Malaji from Bagalkot, Dr. Sunil Deshmukh, Dr. Mrityunjay Mahindrakar, Dr. Arun Kumar Daithankar, and Dr. Bharat Toshniwal from Nanded. It has been a privilege to have such an esteemed group of participants, speakers, and experts come together to share their knowledge and ideas on contemporary HIV management. I want to extend my sincere appreciation to our incredible speaker, Dr. Sanjay Pujari, sir, who generously shared his time and expertise on the therapy. Thank you all once again, and let us continue this journey of hope and progress together. Thank you, sir. Thank you so much for joining today.
Thank you. Thank you.
Good night, everyone. Thank you.
Thank you, everyone. So we are ending this meeting.
Okay. I'm leaving the meeting, Vivek. Okay.
Yes.
Okay. Thank you so much.
Thank you.